Respected teachers, I'll be presenting a study on Topoguided Photorefractive Keratectomy and combined with collagen cross-linking, a new paradigm in keratoconus management. As we all know, keratoconus is characterized by steepening and irregular astigmatism. The main concern for the patient is the best corrected visual acuity. If at all, if keratoconus progresses, we might have to do collagen cross-linking alone. But even though it causes stabilization, it does cause some amount of flattening, but which is totally unpredictable. And corneal irregularity still persists. So most of the patient end up not accepting with the spectacle. So we might have to give them RGP for long term. So, if we combine with collagen cross-linking with a topoguided regularization of the cornea, definitely it flattens the cone peak, resulting in a flatter and broader cone, thereby redistributing the biomechanical strain, so that CXL will have an additive effect on this. So with this background, we did a study after our institution ethics committee clearance to evaluate the clinical outcomes of combined topoguided PRK and accelerated collagen cross-linking in progressive keratoconus with thin corneas under modified protocols. So our methodology is like the keratoconus patient visiting to our the cornea clinic. Our main inclusion criteria was age more than 18 years and the thickness, expected thickness of more than 350 microns following the procedure, which is difference from what we have in literature. Usually literature mentioned till now studies was done for the thickness of more than 450 microns. And hypersensitivity to riboflavin or pregnancy and lactation was the exclusion criteria. About 30 years of 30 patients underwent combined topoguided PRK with modified accelerated protocol. So this was done with the help of a refractive coordinated system, wherein usually after subjecting patient to a routine clinical and slit lamp examination and post-mediatic test or subjective refraction will be done. After that, the patient will be exposed to topography, atlas topographer to have the anterior curvature imaging. Later on, the same data will be transferred to CRS master, wherein we have to enter few values like the thinness pachymetry and subjective refraction and optical zone. Here we can interplay between 5.5 to 6.5 millimeter depending on the thickness and topography. So once we press F2, it actually shows the ablation pattern, which will be definitely focused on our cone, and also which can be further confirmed by 3D representation, which is also given in CRS master. We can actually see our ablation pattern is exactly targeting the cone. After that, the patient will be shifted to MEL 90 platform, wherein we do a routine PRK after alcohol epithelectomy, and PRK will be done. The one difference is like MEL 90 usually takes 2 seconds for every diopter, but here it usually takes more time of about 15 to 18 seconds to complete the treatment, because apart from treating the cylinder, it also regularizes the cornea. So which can be further confirmed in our post-op imaging, which actually shows there will be complete flattening of the cone, which confirms our treatment is definitely helpful. So this can be further confirmed by our follow-up topography. When you actually see this is a 2-year follow-up of a patient, which actually shows Kmax flattening of about 4.5 diopters and astigmatism treated for about 2.2 diopters. So coming back to our results, a similar procedure was conducted in about 30 eyes, and we followed up for 2 to 3 years. And when we actually see, there was more than 50% of the patients gained 3 or more lines just with spectacles, and the requirement for contact lens was drastically reduced, and more than 25% gained 2 or more lines, which was statistically significant, which was further reflected in our keratometric values. There was gradual the flattening of the cornea, which remained so far till 3 years, and no eye has been progressed over a period of 3 years. So with this background, I'd like to conclude simultaneous topo-guided PRK with CXL is a safe and effective surgical alternative for early keratoconus. This combined treatment is capable of offering patient good functional vision as well as stabilization of the ectatic disorder. With this background, what are we adding to the literature? Usually, till now, the publication says we can treat topoguided up to thickness of 450, but we have done the study by considering up to 350 microns, and maximum ablation depth achieved was up to 90 microns, and none of our cases have progressed till now. So we would like to recommend, it is usually indicated for a clear central cornea with ideal central cone with expected thickness of 350 microns. Maximum ablation can be done up to 80 to 100 microns with an interplay of optical zone of 5.5 to 6.5. Thank you.
Thank you. Just a couple of questions. Did you encounter haze in any of these patients? Because you are ablating quite deep. Yeah. And secondly, what was the minimum pre-op that you had, and how did you get to the 350 level? Was that with the epithelium, without the epithelium?
Without the epithelium, ma'am. So without the epithelium, it is 350. So we put hypotonic, it will become 400. And we have even tried for the thickness up to 320 microns also. For that, we have a modified protocol with a calculator. We adjust the dose according to the thickness.
Okay. And what about the haze?
Ma'am, we use mitomycin C in all patients, 120 seconds of 0.02%, irrespective of the era treated. Very less, none of the patient had
120 seconds.
Yeah, and we do start steroids immediately on post-op day 1.
Although you have shown very good results, but that might be a point of concern with the mitomycin affecting the keratocytes and the corneal thickness and ablating a lot of tissue.
Yeah.
So, thank you.
Thank you.